for your attention and welcome. My name is Colleen Davison, and I'm going to help to start the seminar today and introduce our guest speaker. It's really nice to see everyone here and also everyone online. I just want to acknowledge that we're meeting today on the traditional territory of the Anishinaabe and Haudenosaunee people here in Wendat as well. I'm very grateful for the land today in a couple ways. Last night, as the freezing rain was coming down, I was very grateful for my housing, and I was very grateful for the shelter that we have, and today this lovely room and the heat we have here. I'm just very, very grateful for that. I'm also grateful this time of year for the environment and the land, reminding me that there are seasons in our year, and this is a season to maybe take a little bit of a hibernation break, sleep a little bit more, maybe be a bit more kind to ourselves in terms of our mental health, because it's dark, it's cold, and the land was reminding me about that today. So thank you for that. I'm going to introduce our speaker today. We're very lucky to be able to have Dr. Sarah Funnell with us today. Sarah is currently the Associate Dean and Chair of Indigenous Health at Queen's Health Sciences, and she works with me at the Nest over in 15 Arch Street on the 4th floor, if you want to come and visit us. Sarah leads the efforts to incorporate Indigenous health and cultural perspectives into health education, administration, research, and clinical practice here at QHS. She's a First Nation family physician, public health specialist, and clinician scientist. Her background is mixed Algonquin and Tuscarora. She grew up among the Mississaugas of Alderville First Nation, and she's a band member of Kitigan-Zibi. I'm going to give you a little bit of a taste of her experience because I want you to get a sense of the diversity of her experience, but also if there are aspects of it that really speak to you, then you can approach her after and ask her more about this. So Dr. Funnell's career in healthcare spans over 2 decades. She began as a radiographer, but was previously a family physician at Ottawa Centretown Community Health Centre. She provided care there to diverse patient populations in the urban setting, including street-involved, gender-diverse, New Canadians, and Indigenous patients. She also has worked as a family doctor in Akwesasne First Nation, and from 2018 to 2022, she was the Associate Medical Officer of Health for Ottawa Public Health. She's also an assistant professor in the Department of Family Medicine here at Queen's and previously at the University of Ottawa. So please join me in welcoming our speaker today, Dr. Sarah Funnell.
Miigwech, Colleen. Okay, this looks different. I can do it, Nikki. Just rest, everyone. Oh, yeah. Miigwech, Colleen, for that wonderful introduction. It's been so wonderful working with Dr. Davison in the Nest, and thank you for the reminder that it is hibernation season. Why do exams and deadlines always occur at this time of year, right when we want to sleep? I heard some of you talking about some soul food while you were walking in, and remember to feed your soul as well. I wasn't sure if this photo was just too soon, but here we are. I wanted to just have an interactive chat about nothing about us without us in Indigenous health policy and research. And I hope that you're all awake enough to interact with me. I prefer that. But just to let you know, I thought what we could do is identify the root causes of Indigenous health inequity. It's one of an exercise that I enjoy doing with anybody I can chat with. And we're going to roll into defining the role of researchers and policymakers, in particular, those of us that work or want to work in the public health sphere. And then let's see if we can really push ourselves to think about how to apply the principles of self-determination and sovereignty in that type of work. And if those terms are new to you, don't worry, we will unpack them as we go. And so I need to let you know that some of the things we're going to talk about together make us feel uncomfortable. Like they certainly make me feel uncomfortable. Whenever I have a conversation about Indigenous health and equity, it brings up lots of emotions for me and the people that I talk to. And that is like, I'm not a psychologist, but I feel like that's normal for us. Because as Colleen mentioned, like this land that we're on is so beautiful and we have so much to be grateful for. And at the same time, this nation is built on, colonialism, racism, and truthfully genocide. And so though holding those two truths at the same time are very uncomfortable. And that's okay. And lots of people deal with that discomfort in different ways. And so I want you to know that I don't blame any of you for the situation that we have here today and what this nation was built on. But together, collectively, we can make a difference. And I truly believe that. And so today, when I talk about colonialism and racism and genocide, I'm speaking from an Indigenous perspective in this nation some of us call Canada. And that is my reference point. I don't have expertise to talk about racism and genocide in other contexts. So all that I'm talking about is what's happened historically on these traditional lands of Indigenous people. And so we take a pause and recognize that with great power comes great responsibility. And this is like a bit of an ode to my daughter Jojo, who's 12 and loves Spider-Man, but I think it's actually because she's in love with Tom Holland. But anyway, we have many debates about who was the best Spider-Man. So Jojo strongly feels it was Tom Holland. But in all seriousness, I really love the sentiment that this statement gives us. With great power comes great responsibility. And I think sometimes as learners, maybe you don't feel powerful, or as a cog in the wheel of an institution like Queen's or other places that you may have worked, maybe you don't feel like you have power. But if you really think about it, you do. And there's this Indigenous researcher named Sean Wilson, and he wrote in this collaborative book that he wrote on research and reconciliation from 2019. Oh, when I read it, I was so excited to see that he had quoted Spider-Man. And he says, with great power comes great responsibility. But he also talks about research as ceremony and research as reconciliation. And I really love that. And that proper research will force us to become agents of true reconciliation. And when I think about research, I don't think about necessarily, randomized control trials. I think about all research, and I will substitute the term research for other things like public health interventions or public health services and programs or policy decisions. So all of that you can insert as proper, whatever the work that you're doing will force us to become agents of true reconciliation. And so just a word about language, because today, in the short time that we have together, I'm going to be saying Indigenous people. Maybe I'll say First Nations, Inuit, and Métis people. But when I say Indigenous people, I think it's important that we all recognize that Indigenous people were diverse. First Nations, non-status, status, on reserve, off reserve, Inuit people, Métis people, mixed people, and that all of us collectively have experienced common things together, like colonialism and racism and land dispossession, but our strengths are different and our cultural traditions may be different. And so today I'm just going to say the word Indigenous, but please know that it's very layered and it's much more complex than what we're going to talk about today. And so I love bringing in cases in real life to discussions that I have with people. And so this is a picture of me in my first year at Ottawa Public Health. And I was running all over the place, working in public health, working in Akwesasne, doing research, working here. And I pulled out all of these cords from my bag to try to figure out which one I needed at that time. And so that was before AirPods, I guess. But think about this. So put yourself in this position, whether you're a student or a teacher or a researcher or a leader in public health. You are leading a research program, you're leading an intervention, you're designing programs and services, you are leading a health policy document. And in that, you've been tasked to address Indigenous health inequities. When it's open, just keep it open. Or you're applying for a grant to examine, this is very specific. You'll see why in a minute. You're applying for a grant to examine Indigenous life expectancy. Just insert whatever you want. Does that resonate with people? Like, or you're in a group project and you have to examine Indigenous life expectancy. Whatever you can see yourself in, I think it will make this conversation more meaningful. So this is me, where do I begin? I need to plug in my computer. Kind of like my nightmare of like, I don't have a USB key to do this talk. So where do you start? Any ideas of where you would start? Think about it. Because when I started at Ottawa Public Health as an associate medical officer of health, I was handed new initiatives and I didn't know where to start. Well, one example was homelessness prevention, and thank you for bringing attention to how grateful we are to have a roof over our heads that's not leaking, that's warm and we're comfortable and we feel safe. So where do you start? Well, some people start with data, so let's do that. I'm not saying that's the right thing to start with, but let's just do that. Okay, so we talked a bit about putting ourselves in this position that we're doing a group project, maybe on Indigenous life expectancy, or we're starting a big program on how to extend people's lives, like what can we do to prevent early death, whatever it is that you're doing. And so this is where I'd like you to interact with me. And so I do this with the public health residents all the time. We throw up a graph and they're expected to be able to analyze it. They do this in internal medicine too. They'll throw up an ECG and you're expected to like know how to read it. So, or an X-ray. So we'll do that with this figure. And so what is it that you're seeing? And this is when you're going to tell me what it is that you see. And Vic's not allowed to answer because he's been through this exercise. Yes.
So we're looking at a graph where we have First Nations in red, Métis in blue, I believe Inuit in white, and total population of Canada in the slashes. And it looks like the total population of Canada is higher in both males and females relative to the the Indigenous groups.
The life expectancy is?
It's higher among people, the total population of Canada, and it's lower among people who are First Nations, Métis, and Inuit.
Yeah. What do you know about life expectancy? What does that tell us? Yeah.
Well, it's like a measure of many factors, but besides like health conditions, it's also like social supports and other like social determinants of health. Like, what are the resources that are available to you to achieve optimal health and income? Different, like, there's many things involved in terms of life expectancy besides just health conditions.
Right. Yeah. So there's multiple factors that contribute to this estimate of length of life. It's a measure of population health. And what is it that's unique about life expectancy? It's different than the average age of a population's death. Yeah.
Well, I guess you kind of have it at the bottom of the slide, right? But essentially, you're estimating how long someone will live, like someone who's born today, how long they will live.
Yeah.
Um,
Right, and there's different ways to calculate that, but this is not a hardcore demography or epidemiological talk. But there are ways to do that. And so in this example, what we're seeing is that life expectancy, so how long you're expected to live at birth, differs by your race. And that's why I share this slide and this figure, is that being born First Nations, Inuit, or Métis, just by being born, you're expected to live fewer years. How do you explain that? And you said it's very complex, right? But I think the most important thing that I want you to take away with you is that it's life expectancy based on race. And the only way I can explain that is that racism is operating. And so this is another way of looking at it over time. And so you can see that over time, life expectancy is lengthening. We are expected to longer if we're born in 2011 versus 2006. But that there's still a difference. That even though people are expected to live longer, even if you're First Nations or Inuit and Métis, you still, at being born, you're expected to live fewer years. And this is another way of looking at it, by gender. Okay, so how do you explain that? So we looked at a graph, a figure that showed us that you're expected to live fewer years if you're born Indigenous, which is First Nations, Inuit, or Métis. How do you explain that? So I said racism is operating, but how does that work? I'm not being facetious, I want you to talk to me. So what's happening? What do you think is going on?
Like lack of access to health care services, lack of access to other resources that the general population has access to.
Okay, so there might be, an access to health care. Okay, so if you needed care, you couldn't get it for some reason. Okay, yeah.
There's a multi-cohort of health determinants, social, physical, everything that comes together.
Yeah.
And everything's very specific on how it works, but in class we were talking about the mistrust that Indigenous communities usually have in the Canadian health system for very valid reasons. So that could also be a factor.
Right, so there's an access problem, there's a mistrust. And I think the two of you are talking about healthcare, is that healthcare system, right? What else could, beyond the healthcare system, what else is happening? Yeah, over here.
Could it be the intergenerational trauma that the Indigenous people has been going through that has impacted their health in general and the life expectancy, how long they can live because of what they have gone through?
So excellent point about intergenerational trauma that children, Indigenous children today may be the children of people that went to residential schools somehow intergenerationally. They may be children of parents that were forced to be adopted in the 60s scoop or their grandchildren. So that trauma is passed through generations. That's called intergenerational trauma. How does that operate? How would that decrease the length of life if anybody wants to pose an idea of how trauma would decrease someone's life expectancy or intergenerational trauma? Yeah.
Would be increased risk of substance abuse and associated conditions.
So substance abuse, yes, could be. Any other ideas how intergenerational trauma might operate? Yeah.
Like mental health and suicide rates.
Mental health, suicide, other things. Yeah.
Like I'm just thinking just having heightened cortisol levels in your body for your whole life growing up. And then when you have kids, they might also learn that behavior from you, unfortunately, despite your best intentions, because it can transfer onwards.
Could be that too.
Or like, can make it harder to get a job or education, which affects families.
Right.
Yeah.
So loss of identity and loss of community connection
Mhm.
from, because they have been displaced from their birthplace and displaced from the community. So yeah, your values and everything has been lost through that.
All of these things could be operating, and like you said from the beginning, that life expectancy, many things go into that. And so the idea about intergenerational trauma is, if you're not aware of the adverse childhood score, what's the E stand for? Experiences, yeah, score. I mean, I think that's related to intergenerational trauma and how that affects children and their overall health. So, at this point, like, what are some other health inequities that you're aware of that relate to Indigenous populations?
Remote access communities have, I think, less access to fresh produce, so they're the cheapest foods are often the ones highest in fat, the unhealthiest foods.
So healthy foods, okay, so there's food security. Yeah. You and then you.
Other environmental factors, so for example, clean water and
Clean water, air, yeah, excellent, yeah.
Also increased rates of certain infectious diseases, like increased rates of TB among certain communities, things like that, related to some of these other social factors.
Right, yeah, so higher rates of tuberculosis in some Indigenous populations, not all, but some, certainly that, yeah, that's an important inequity to recognize. Anything else come to mind? Yeah.
Lack of access to the prevention measures.
So lack of access to prevention measures, like what would, are you thinking?
Vaccination and screening test for the early diagnosis of many diseases.
So, vaccination, you say screening tests? Yeah, which types are you thinking of?
Or I would say cancer.
Cancer screening?
Then also because of lack of access, diabetes at early stages because of the dietary change that they had, and hypertension. So those conditions.
Right, okay. So if we were to do like a root cause analysis exercise where we take one of these health inequities and unpack it, we would get to what's operating in this in Indigenous health. And so if you'll allow me to guide us through an exercise, I'd like to unpack infectious diseases, because I haven't done that in a while with the group. So we good to do that? And let's use your example of tuberculosis. So I'm gonna ask you a few why questions and you just answer me back. And if people are on Zoom, you wanna communicate through the chat, that'd be great. I think we have people in the room monitoring, so please feel free to communicate with us in that way as well. And so why would Indigenous people be more likely to have tuberculosis? So why do you think that would be? Yeah.
Crowded living conditions.
Okay, crowded living conditions. That is one very good reason. That's a great place for tuberculosis to spread, like COVID and other respiratory and diseases, communicable diseases. And so why would Indigenous people be more likely to live in crowded conditions? You don't have to be the one on the hotspot. Other people can answer too. And those of you at home also. Yeah. Lack of adequate housing. So why would you find Indigenous people having a lack of inadequate housing? Go ahead.
I don't know about in terms of officer, but officer, I know there's a systemic lack of funding for building adequate.
Okay, so there's some sort of like policy decision being made, right? That's where the health policy ideas start percolating. Okay, so somehow there's been a decision made, because it's a decision that's been made to not invest in adequate housing. So why does someone get to make a decision like that? Some people. Someone's made a decision. I'm not saying who, I'm not pointing fingers, I'm just saying this decision has been made. Or it's being fought somewhere. So how is this allowed to persist? That there's not investment in adequate housing for Indigenous people? Yeah.
Not really an answer, but more of a comment that the decisions that are made reflect the values of the people making those decisions. And if those decisions aren't being challenged at that level, it also reflects the values of who's invited into that process and the systems that exist that create those barriers.
Right, so there's, I'm guessing, I'm not saying this is actually what's happening, we're just sort of analyzing the situation as best we can. But there's the people that are making those decisions aren't including the people that are involved, right? So that's a lack of inclusion in the decision-making realm, maybe. Okay, so why are Indigenous people living with inadequate housing not included at the decision-making table? Why aren't they not included? Possibly in this scenario. Any ideas why that is? Yeah.
That would mean they would have to shift the power over.
Power sharing. Yeah, I think so. I think so. And I think some others in the room think so. And maybe some of you on Zoom think so as well. That there's about power and maintaining power of certain people, not including Indigenous people that are living in poor housing, to be part of the decision making. It upholds power. And what does that power serve? Like, why do people want to maintain power and not include and not power share with others that are living this reality? Okay, back over.
Power allows you to have control over what's happening, which also gives you control over what your status is. And oftentimes in society, people who have the power like to keep the power so they can keep their social standing and social hierarchy and not share it.
Giving up power is scary, right? Like when I don't mean to sound like shallow, but when I drive in a car with my husband and he's driving the car, I don't like it. Like, it's terrifying. So giving up power is frightening, right? And people may not lean into that. You think of all kinds of different reasons why you don't want to give up power. And then there's these narratives that happen. Oh, well, they're not, like, I've been driving longer than him. I drove country roads. He didn't drive country roads. All of those reasons, but really I don't want to give up the power. And so I've never used that example before. I can't put it down about it. Oh yeah, okay, when he drives, I close my eyes. But anyway, so yeah, it's about giving up power. And in the Indigenous context, decision-making has historically been about others with power making decisions about Indigenous people for them. And I don't think that's turned out so great. I don't know about all of you, right? So, and what does holding on to that power serve is the question that's very unique in this place some of us call Canada. It is a unique, special circumstance. And so certain people are holding power over Indigenous people. Why? What does that serve?
So is that to serve controlling people for their land, as you have on the slide? But
Yeah,
I
think so, and I think a lot of other people think that too. And people with lived experience certainly feel that too. Other people are making decisions about us, right? And then what does that serve? And so if we were to do like a historical analysis and apply our social science theories to this, we would get to racism is about power and control over people. And in the Indigenous context, it's power and control over Indigenous people, First Nations, Inuit, and Métis people. And many of us feel that and know that that was about land, and it continues to be about land. And we started off talking about land. This land is truly beautiful and it's rich with resources. And so just a summary of what we just talked about is that there are these determinants of health. And I love this framework because it's divided into distal, intermediate, and proximal determinants. And as a healthcare provider, which I am, as well as all the other things, including being a terrified passenger when my husband is driving, that there are direct impacts on health that we can see. And often we identify these as the determinants of health and the determinants of health inequities. But if we look deeper, like we just did together, you can see that there are these proximal determinants of health, and that the distal ones are the most powerful that determine how all the others flow. So colonialism, racism, discrimination, and the lack of self-determination. So not being included or not being in control of making the decisions. And so I love sharing this quote from my colleague, Dr. Marsha Anderson, who's also a public health specialist. And she says, from now on, instead of vulnerable people, I'm going to use the phrase people we oppress through policy choices and discourses of racial inferiority. It's a bit longer, but I think it will help us focus on where the problems actually lie. So if you're in a group, or you're writing a grant, or you're developing an intervention, a public health intervention, think about where the problems actually lie. Like, do that root cause analysis. And like what we just did today was really simplified. As we know, it's much more complicated. And so these are choices that have been made somewhere. So what is our role as public health people? Learners, researchers, teachers, professors. What is our role in all of this? We started off by talking about how we have power, and how do we use that? So what do you think your role is? Or as learners, what are your roles in all of this? Because it's overwhelming. I would make you sit here and I'd wait it out, but we don't have a lot of time, so you're lucky. But I just wanted to highlight that, you know, there's the Truth and Reconciliation Commission, and this is one of the calls to action. And it talks about establishing measurable goals to identify and close the gaps in health outcomes. And so there's, you know, some interventions to think about. And these were at the time, the issues that were identified as infant mortality, maternal health, suicide, mental health, addictions, life expectancy, birth rates, infant and child health issues, chronic diseases, illness, injury, incidents, and the availability of appropriate health services. So we do have a bit of a guide, so we don't have to make it up. And so if you're assigned a project or a task or whatever it is, you can look to what exists to help you prioritize what are likely the most important priorities of Indigenous people. and that's the Truth and Reconciliation Commission calls to action, the Missing and Murdered Indigenous Women and Girls report, and their calls to justice. And the reports will just keep coming. So in terms of like research or program development, you need to know that not only did our residential schools, you know, have all of the other atrocities that occurred, there was also nutritional experiments conducted on children in residential schools. And so a lot of Indigenous people have a mistrust of the healthcare system, the education system, researchers, and if you want to work with Indigenous communities, you have to build trust. And this is only one of the reasons why. But if you didn't know about this, there's a lot of other writings about the nutritional experiments. I encourage you to take a look at those. So how can we, as public health people, address all of these inequities that we talked about today? Or how can we use our tools and our power to make a difference? Do you have any ideas about that? Or maybe you have your own experiences that you'd like to share. How can we together make a difference? Because I need people to help. Yeah, go ahead.
I think just start by measuring and trying to understand what the inequities actually are.
So measuring and understanding the inequities. I think that we do need to do a better job at that. And sometimes in talks, I talk about data governance. This isn't one of those talks, but that we have to be careful how we do that and make sure we use our critical analysis of what it is that we're seeing when we see those measures, like we did with life expectancy, like we did with tuberculosis. Yeah.
I think whatever avenue you're taking in research or policy or whatever, it's actually inviting people into it. So practicing that power sharing, co-creating interventions, co-creating research, things like that.
Yeah, I'm glad you said that. Because the other thing I wanted to leave you with is this idea of self-determination, and that as Indigenous people under the United Nations Declaration on the Rights of Indigenous People, that we have rights to determine for ourselves what it is that we need to be well, and the right to traditional medicine or traditional practices. And so these are rights. So it's more than inclusion at those decision-making tables, but it's changing it to a rights-based framework. And so self-determination it might look like, don't make decisions about me without me. So nothing about us without us. There's lots of supporting frameworks out there to guide us to do this type of work. For one, there's Chapter 9 of the Tri-Council Policy Statement on research involving First Nations, Inuit, and Métis people. I feel like this framework also works really well with policy development or program development, and it takes that approach of nothing about us without us and self-determination. We talked about data, that it's important to understand data and understand what's happening and what are the inequities and measuring those so we know if we're making a difference. And it's important to recognize that we have these principles. This is a First Nations framework of ownership, control, access, and possession. It's about data governance. So there's that to guide us as well. I love that this is really quite old, but it's 6 Principles of Métis Health Research, which I, again, do feel applies to beyond research. I think of research very loosely, but it also includes, policy development, program development, and it's about reciprocity and respect and safe and inclusive environments, recognizing diversity. So not only is there diversity across Indigenous populations, there's diversity within each group. So Métis people feel that this is important, that you all understand this. I'm not Métis, I'm just sharing this with you. and that we need to understand the Métis context. The Inuit people, Inuit, have also organized some thoughts and recommendations around research and health policy with relation to Inuit health. And they have 5 priority areas in their strategy. That's me reminding me to stop talking soon. So there's that to guide us. And so how do we ensure we adequately have Indigenous people leading health? And so this is a framework that I love, because I can't tell you how many times I've heard that, oh, Indigenous group so-and-so, they're engaged in this. But what does engagement mean? It can mean like, I told you, so you're a group and I told you, I just wrote this paper on you, about you. I've informed you. Or I consulted you. I'm gonna write a paper about you. And I'm wondering what you think about this survey question. I've consulted you. I involve you. I say, hey, help me write the survey questions, because I got this great idea that I want to do. Or I can collaborate with you, which is a little deeper. We're going to work together. We're not just going to write the questions, but we're going to determine what it is that we want to inquire about. And then empower, I feel like I gotta deal with this term empower, because I feel like it's a bit benevolent, but it's like, you know what? I'm gonna just let you do it, and I'm gonna be here if you need me. Whereas self-determination is totally different. It's like, I'm backing out and I know that you have the right and you can do this yourself. And then, but we're not there yet in all spheres. In some cases, Indigenous people are exerting that right to make decisions and develop interventions and do research and do all those things. But until we get there, and in spaces like this, where we have colonialism operating, that there's still hope that we can work together in an ethical space where Indigenous values are respected and all the academia things that we've learned in our academic institutions are valued, and we come together to build something really cool, really beautiful. And it's called this ethical space. Some people call it two-eyed seeing. And it's a similar principle where 2 worldviews come together for a collective cause. And I think that's probably where we're at in most cases. And that's what I want to be involved in until we get to that point where Indigenous people decide. And so a reminder that with great power comes great responsibility, and that the work that we do, we can become agents of reconciliation. And so in summary, I think we identified some root causes of Indigenous health inequity, particularly racism in the Canadian context. I hope that we find our role a little bit. And I really hope that you go away really thinking about ethical space versus self-determination, or how they operate together. Because I think that's, that would be a cool place to get to. And with that, I say miigwech and thank you. And I think there's a little time for questions.
I don't think I need to organize Sarah's question and answer, but I just want to make sure that everyone feels welcome online. Nikki is watching the space as well as in the room to ask any questions that you have for about 5 minutes. Please do so.
Yeah, go ahead.
I know there's been a few sort of high-profile cases lately of Indigenous people having a different background than they originally claimed. And I'm curious about your insights into that and what your opinion is in terms of what should happen going forwards at Queen's and also like on a national level.
Yeah, I mean, that's an important question. I guess not necessarily like why we came together today. It puzzles me as an Indigenous woman why someone would ever want to pretend to be an Indigenous person, particularly an Indigenous woman. If you look to the Missing and Murdered Indigenous Women and Girls report, you can see that we talked about life expectancy today, but just by being born an Indigenous woman, you're more likely to go missing or murdered. So I don't know why people do that. It's for some perceived benefit. And that's all I can say about that. I know we're working very hard at Queens to ensure that doesn't continue to happen. Yeah.
Great talk. Really interesting. It got us all speaking, which is good too. I wanted to ask if you have any suggestions for students who want to get involved in this type of research, particularly if you have like a limited time frame. Like, do you have any suggestions? Like, that's, I guess, the big drawback sometimes if you're only here for a year or two.
Yeah, I hope that there are still parts of a research project you could do, but time, yeah, that is a tough question. I've been there too. When I did my master's of science in epidemiology, it was extended. Like it was longer than expected because I was working with the Canadian Indigenous Nurses Association, and most of the time that we spent together was developing an agreement on how we would work together. And really that was like the most important part of my experience doing my master's work, was developing that relationship. And so I think that, you know, the actual like research question that we had, like, you know, that we answered that question, it was fine, and we, you know, presented on that, and there did the whole like methods, limitations, all of those things. But really, like, what was most meaningful to me was the long-term relationship I developed with the individuals that were at the Canadian Indigenous Nurses Association, and our continued like professional relationship as partners in many things. So it's hard to answer that question, but I think like concretely, if you're able to find a supervisor that already has those connections and you support that project, big research project in some way, I think you're going to be more successful. But to know that this is a place where you can't speed up the timelines, like it just doesn't work so well in most cases. I don't know.
No, I would say the same.
Okay.
Yeah.
Yeah.
If I could just say that one of the failures and the reason for research failing is that you don't build in that time to build those relationships. And we saw that in Thunder Bay, I saw that in Sudbury, I saw it in Northern Ontario. And your boss is saying, well, you've done this for 2 years, what have you done? And that is really, and it is 100%, you're gonna fail if you do not build those relationships.
Yeah, and I think it comes down to like worldviews of what is more valued. And so like, I know like when I did my master's of science in epi, like that what was valued by the institution was my completion of my research project. And that was stressful because that had to be done. And each time I had to lengthen it, I paid more tuition. Like it was all very real and stressful. Whereas and there's this other journey happening at the same time where I'm developing relationships, which is maybe more valuable. I mean, how do you measure the value of that? But I think it's that relationship building that will take you beyond that research thing that you're doing at that moment. And maybe if we thought of different ways of reporting or different ways of scholarship, we could show that, you know, the relationship we developed is maybe more valuable than that research project that we did that's sitting over there. You know, I don't know. Those are just my random thoughts about it.
I think I'm gonna, because it's 1:20 and we should wrap up for the next user of the room. I want to thank Sarah for being with us. I also want to thank the Health Services and Policy Research Institute for co-hosting this for us today. It was really nice to see a large number of people online and in the room. So thank you for coming and thank you for supporting the seminar series. Do we have another one before the holiday break?
This
or
is the
no?
last one of
This
the.
is the last of the
term.
semester, yeah. So thanks for supporting this whole series this semester, and we'll be back in, I see Catherine Donnelly there. Did you want to say hi?
I'm so sorry. I had wanted to be there in person. I was in a meeting I couldn't get out of. I just want to say thank you both at Public Health Sciences and Sarah for collaborating on this rounds today. Thank you so much. What a great way to end the term.